Thank you very much. Moving on. It is my huge pleasure to introduce the next speaker, PhD in medicine, Victoria Skidan. We've been friends for a long time with her. She represents consultancy and diagnostic department of the Federal Center for Cardiovascular Surgery from Khabarovsk, from Russia. Obviously, our geography is expanding. We're going east. It is my pleasure to give the floor to you, Victoria. The talk will be, as per the previous announcements, isolated hypoplasia of the left ventricle apex as a rare new form of cardiomyopathy, diagnostic criteria and interventional treatment. Could you go full screen? Andrei, I wish to thank you for the opportunity to popularize. Could you please go full screen? Trying. Just 1 second. Правее кнопочка, там такой флипчарт, видите? Вот четвертая кнопочка внизу, рядом с ползунком. Вот это. Right, going full screen.
Глубоко уважаемые коллеги, мне бы хотелось сегодня представить вам крайне редкую патологию.
Esteemed colleagues, I wish to show this quite rare pathology, restricted hypoplasia of LV apex. It was first classified as congenital cardiomyopathy in Cleveland Clinic, US in 2004. MRI findings in 3 patients were analyzed. Magnetic resonance imaging was analyzed, and similar anatomy changes have been detected, have been identified in these 3 patients. If you haven't seen such a patient in your clinical practice, you wouldn't have known about this kind of cardiomyopathy. But this kind of congenital CMP got us very interested. We started perusing the literature. At this point, we have found 34 publications. We've even written a monograph. And I would like to share the outcomes of this work with you. Most importantly, Andrei gave me the opportunity to deliver this talk to a broad audience of cardiologists, doctors, arrhythmologists, because everyone can face it. So we've only seen 34 publications, 5 of them in Russian, the other 29 are in English. 48 cases of isolated hypoplasia of LV apex. So what is that? It's a rare congenital heart anomaly that now belongs to unclassified cardiomyopathies with restrictive type of hemodynamics, with spheric remodeling of left ventricle, with adipose tissue replacement. So the LV apex myocardium is replaced with adipose tissue. There are changes around papillary muscle and the betterment of the shape and function of the right ventricle, accompanied with clinical heart failure and heart rhythm disorders. From the viewpoint of epidemiology, the pathology has been described everywhere except for Africa. I guess we know why. We can guess why. True prevalence and the incidence is not currently known. These are definitely not all the patients with this pathology in years. However, these are the cases that have been identified and described by experts in literature. These are the main findings, the main works from 2004 to 2019. So different ages, different genders as well, different sexes. In China, from the viewpoint of geography and epidemiology, 8 patients, well, because of the vast nature of the country, 6 cases in Russia and the US, European Union, another 6 cases, UK and Commonwealth, 7 cases, and sporadic cases of Korea and Iran. Mean age of these patients is around 29 years. The age ranges from 3 months to 66 years. Etiologically and pathogenetically, we came to the conclusion that the gene-determined hypothesis can be, well, could be 2 issues. First is the breakdown of genesis, of morphogenesis of the heart in embryogenesis in the early fetal period. or it could be a mutation of the lemmin gene. The lemins are structural proteins, many known cardiomyopathies, autoimmune diseases. The nuclear lamina provides the strength for the nuclear envelope and the organization of nuclear pores. It resists deformation forces and protects chromatin from physical damage. Italian researchers in their article, they've analyzed the analysis of lemmin gene in a family with 2 cases of isolated LV apex hyperplasia. The congenital nature is not even up for debate because the signs are detected in MRI. And in one patient, it was ultrasound, antenatally 3 months old. Standard obstetric screening came up with that. This pathology is virtually symptom-free in children and teenagers in a clear. Why? Because the LV apex is replaced with fatty tissue, with adipose tissue. If we imagine the morphology and the dynamic of contractility of the LV, you know, the longitudinal structure, the deformation, the deformity of the tissue radially. The radial is clockwise and counterclockwise, radial deformation. In children, unlike in adults, it is counterclockwise. So in this case, as the patients grow older, the apex is not contracted because it's no longer cardiomyocytes, it's adipose tissue, it's fat. This is when we see the manifestation of chronic heart failure. In adults, it's congestive heart failure, various heart classes, NYHA 1 through 4, all kinds, systolic dysfunction, mostly restrictive type, decompensation with biventricular chronic heart failure, high lung hypertension, and syncope. One fatal outcome has been described in 19-year-old from Italy. That adolescent died after exercise, after uncontrolled hypertension, pulmonary hypertension. Supraventricular tachycardia, atrial fibrillation, ventricular tachycardia with fatal complications are rhythm disorders, up to pulmonary edema and ventricular fibrillation. That single case presented with that, single case described, that Italian adolescent. Now, the combination of this pathology with congenital disorders, these patients are free from coronary artery damage. There is no atresia of aortic or mitral valve. There is no intraventricular disorders. 30% of patients present with open arterial flow, complete transposition of AV valves, aortic stenosis and pulmonary artery stenosis, as well as concomitant anomalies, the obstruction of the left ventricle outflow, diverticuli of LV, and neocompact LV myocardium, non-compact LV myocardium, which also causes problems with heart rhythm and detecting disorders. In the clinical picture, if you analyze all the articles published to date, the ones that are available on Medline at least, it was found that symptom-free progression is seen in around 70% of kids. Heart failure class 1 through 3 NYHA was found in 73%. The syndrome, the small circle overload syndrome with high pulmonary hypertension, seen in 20% of cases. Arrhythmic syndrome in almost half. Atrial fibrillation, 1 in 4. AV conduction abnormalities, 20% of observations. VT and VF as the cause of death are just sporadic cases. To diagnose isolated hyperplasia of LV apex, MRI plays a key role. And this imaging technology was the first one, was the one used to identify first cases. However, ultrasound is also important. Its importance, its relevance has been confirmed later. The affordability and feasibility of echo is clearly seen in first cases. This can be seen in a conventional cardiography workup This was the case with me. When the patient walked in from the reception area to the ultrasound doctor, I found this patient like that, an ultrasound. So what kind of hypoplasia in the LV apex do we see? Spherical shape, missing pinnacle. There is a intraventricular septum is pumped up. It's tending to the right, like an aneurysm, but its kinesis is preserved. Another sign that our American colleagues have described in Cleveland, Monica Fernandez-Valls, she was a fellow in the MRI department, Spanish cardiologist. Her observations were supported by the clinical, by the professors in Cleveland. Basically, Monica Fernandez-Valls is the pioneer. She's the first author of the paper that described those three initial cases. So first of all is the adipose tissue replacing the LV apex. The myocardium is replaced by fat. Ultrasound is not always detected. It can be visualized as a hyperechoic inclusion or a hyperechoic area of akinesis in the area of LV apex of an oval or triangular shape. On MRI, it's in fat set mode. These areas are hypointense. The third sign is a papillary muscle apparatus. The papillary muscles of mitral valve that are supporting the mitral valve, they're creating the structure in the left ventricle. They are on this flattened apex, flattened LV apex. Subvalvular structures can be missing, they may differ. The papillary muscle length is satisfactory or shortened. The heads of papillary muscles can be hypoplastic and the chordae are elongated. You see the ultrasound presenting with these flattened papillary muscles, PMs. The fourth sign that the American colleagues looked at was the changes on the right ventricle side. It's elongated, it's banana-shaped, banana-like. There is a wraparound of the hypoplastic apex. There is this wrapping around in the hypoplastic LV apex. We know the RV hypoplasia with adipose tissue replaces in the anterior wall, in the lateral wall, with the coming rhythms, ventricular tachycardia. Something similar can be seen in the left ventricle. Maybe it's similar. At this point, this pathology is not classified. Its prognosis is unknown. Medical follow-up is definitely required. For formation of registers is required. Development of standards for medical treatment, drug treatment. Development of strategy for surgical correction of CHF and rhythm disturbances. Evaluation of the possibility terminal cases of heart transplantation. And the place of this nosology in the cardiomyopathy classification needs to be determined. We would like to present our case. We have been following up a patient for 4 years. It's a 30-year-old male. He came in, the initial presentation was at the age of 32 with pronounced AF, CHF, Borg test significant, polycerasitis, heart rhythm, atrial fibrillation, refractory to standard drug therapy. CHF functional class 3, New York Heart Association classification. We prescribed the methodology of radiofrequency ablation of the pulmonary vein, ostia. The methodology has already been determined. The patient came in, they showed up at the office. And basically, we thought it's aplasia, but internet helped us find the description of this pathology. Our patients came with all the classical shapes, spherical LV shape, cutoff flat on top. Also, the ejection fraction was significantly worse than 32%. The basal apical size of the LV was 43 millimeters. It's very, very small. The swelling of the intraventricular septum to the right, same clinical finding. MRI confirmed. Papillary muscles were attached to the flattened top of the left ventricle. There was abnormalities of the posterior papillary muscle. The elongated right ventricle was kind of sweeping around the contour of the apex of the LV. The ejection fraction of the right ventricle also suggested very low figures. Right ventricular insufficiency was also seen in 3D ultrasound. Additional analysis methodologies, trivial additional signs, trivial MR, trivial tricuspidal regurgitation, trabecularity in LV walls. These are the pictures indicative for the LV shape changes, LV shape malformations. Non-compact myocardium of the LV apex, we suspected that, it was confirmed on MRI. Polypositionally, we did the ultrasound. Through the esophagus, we saw the papillary muscles that were attached to the flattened top of the LV apex. And we saw the issues with the valve, the aortic valve without dysfunction. It was displayed into the non-orthogonal plane. Analyzed the ejection fraction, typical picture of akinesis in the apical cap zone and the low ejection fraction. Virtually the same goes for the left ventricle on MRI. Our MRI colleagues have come up with the same findings, shortening of the LV, non-compact myocardium in the anterior and lateral segments. Treatment strategy, given Holter monitoring, there was paroxysm, ventricular tachycardia unstable. We decided to go with the ICD, implantation at the first stage. Given the recommendations, indications, ventricular tachyarrhythmia, low ejection fraction, we went for it. RFA was done 1 month afterward with CARTO system, radiofrequency ablation. All pulmonary veins were isolated. Diuretics, anticoagulants have been added, repolarization inhibitors, because before the therapy, well, the patient had no history of treatment. When we published our article in the cardiology journal, there was a lot of peer review questions. We got the question why the implantation was done of the ICD and not the RFA. Why did it come as stage 1, not stage 2? Why not switched places? Well, it's from bad to good. The implanted lead in the apex of the right ventricle that was coming around to the top, to the apex of the left ventricle, it caused the repolarization to change. And it caused the contractility of the left ventricle. 3 days after the implantation of that ICD, we got the ejection fraction up to 50, which was completely amazing. It was completely unclear at this initially why that outcome was reached. And then we assessed it as a very good result and the right decision that we've made to go with the ICD as the first stage. After RFA, 1 month on, CARTO3 system, PV isolation, we restored sinus rhythm in the patient, and the ejection fraction went up to 58–59%. The size of the left ventricle also came down. It got smaller. The right atrium got smaller, but the left atrium was quite big. It stayed quite big. 62 millimeters indexed area. So essentially, this is dilation, and quite significant one. So there was a question how much time we can maintain this patient on sinus rhythm. In 6 to 12 months of follow-up, it turned out that there are no problems there. The sinus rhythm is perfect, great tolerance to physical exercise. Borg test 650 meters in 6 minutes. Modified scale, modified Borg scale. You see even visually the ultrasounds. We're not ultrasound diagnosticians, but we can see how well the ICD helps contract the left ventricle. Mitral, tricuspidal regurgitation went down. The ejection fraction is 54, very good stroke volume. And we see the reduction of the akinesia zone in the left cap of the ventricle. So basically, we have done the right thing prescribing this treatment. There was objective proof of that. So restrictive changes of diastolic functions, tissue Doppler confirmed it. It stayed. That pathology stayed. Quite high pulmonary hypertension up to degree 2, second degree. We started following up on the patient. 2-year follow-up helped us show sinus rhythm is there, the chambers of the heart are not changing. The heart model on picoseparators, you see the LV and LA. The LA is 100 milliliters, normalized to area 54.2 milliliters per kilogram per square meter. Basically, this patient will have a hard time maintaining sinus rhythm. And we got the confirmation by the CareLink system. When the endogram was recorded, was ventricular tachycardia with subsequent rhythm restoration. There was a false shock we saw because of the paroxysm of AF up to 300 BPM ventricular beats with subsequent sinus rhythm restoration. Such episodes were seen several times throughout the year. However, sinus rhythm was still there. 3rd year of follow-up, same story. And only after almost 4 years, the sinus rhythm got disrupted. So there were again paroxysmal paroxysms of atrial fibrillation. Then there was persistent AF. This is why we went for the repeated surgery, repeated RFA. Again, PV isolation. And the mitral isthmus and the LV apex was done in April this year, literally a month ago. So I believe this case to be quite interesting. We should spread the word. We should promote these findings. Many of us will see this as clinicians, as diagnosticians. Many of us are likely to face this cardiomyopathy with 4 typical MRI and echo KG findings. Clinically adverse outcomes because of heart failure and LV-RV dysfunction, pulmonary hypertension, rhythm disturbances, and fatal VT. Medication and interventional treatments should be aimed to compensate the manifestations of CHF and prevent cardiac arrhythmias. Thank you very much for your attention. Dear colleagues, thank you very much for your attention. I'm sharing my screen, right? Yes, thank you so much. Thank you, Victoria. And dear colleagues, any questions to Victoria, please fire away. Surgical people, where you at? A rare type of cardiomyopathy, a rare type of CMP. And if you can recall, dear colleagues, we had a webinar, dedicated webinar on that. We will remember it today. It was dedicated to cardiomyopathies. So any questions? Victoria, may I ask you a question? I didn't quite get the mechanism of LV improvement after ICD implantation. Can you comment on that once again?
И сразу вопрос, а назначали ли вы этому пациенту с 2017 года антикоагулянты?
Да, он получает.
То есть он, нет, вот сейчас-то я понимаю, а тогда?
No, now I understand, but back then, what about back then?
Сейчас
No.
он получает Eliquis.
So now he's on Eliquis, Eliquis 2.5 grams twice a day, standard dosage. Initially, no, it wasn't the case.
Исходно как сердечная недостаточность.
We were managing him with heart failure, paroxysmal atrial fibrillation, then we threw anticoagulant on top.
Еще вопросы?
Any further questions?
Я хотела просто показать эту картинку, где
I just wished to show that picture with a banana-like RV apex wrapping around the LV apex. Yeah, I remember it. When in correspondence with our English peer who was reviewing our article, our article about this patient was published in the European case report, European Heart Journal. Case report was there. There was a lengthy discussion, and it basically got us all to conclude that most likely the conductivity of the agitation, somehow the lead affected the apex of the LV, and it kind of affected the ejection fraction, improved it. Thank you. Any further questions? I don't see any. Thank you very much indeed, Victoria. I hope you will stay on. You will not abandon us. I'm very happy that we've been able to expand the geography of our speakers. We love our centers. We've been there multiple times. Our best regards to all our friends there. Thank you. We love you guys too.